Hello guys, hope you are doing good. This is your physiology faculty, Dr. S. Krishna Kumar, and here we are for the recall session. Now the INI-CET November is done and dusted. This is about the recall recording concerned with physiology. In this recently concluded INI-CET November session, particularly in physiology, I got around 11 questions, but we definitely know it is more than that. This is pure physiology questions, but in relation to other subjects, there were few more. But here we will discuss that important 11 questions. So this is a recall based one. So any queries, any clarifications you had, please get back to us in the Facebook group Marrow Links or my Instagram page at Krishna Kumar Solayappan. You can get back to me for your any queries or clarifications. Now we will go to the main sessions, particularly in physiology. What were the questions asked? First question, look carefully, just try to understand and answer. In my opinion, this recall sessions have to serve one important purpose, that is pattern recognition. What is the meaning of pattern recognition, sir? What the examiner or the exam is all about. They follow a particular pattern, and particularly for INI-CET, it is largely clinical integration and very minor twist of basic facts. Clinical integration and very minute twist of basic facts. That's what they are doing in the last 3 to 4 years. So recognize the pattern, and it is also a very important learning tool. This recall videos and all for our future upcoming exams. Look into this first question. An image of the brain with 4 areas marked is shown below. Which area is responsible for scanning the visual field? So obviously it is basically asking whether it is frontal, parietal, temporal or occipital. Any guess? I hope you answer this question correctly. Scanning is definitely frontal eye field. So what should be the answer here? Option A, frontal eye field. We need to remember the brain areas concerned with vision, an important table for you. First, let's start with the thalamic nucleus. What is the thalamic nucleus for vision? Very simple. It is lateral geniculate body. Remember, vision, light. L for L, lateral geniculate bodies. Then our visual cortex, which is area 17, which is striate cortex because of the classical myelinated fibers giving the stripe-like appearance. Primary visual cortex in the occipital region. Where exactly? In the calcarine sulcus. Next, someone is asking you to look there. You will ask where? So where? What is that? Motion. If where you have to look, your eyeballs will automatically move. Where? That eyeball movement motion is because of parietal cortex. Then you will ask, what is there? What is there? I am looking there. What is there? So that recognition, object recognition, what pathway is temporal? See where? Motion, parietal. What is actually there? Object recognition, that is temporal. So where is parietal? What pathway? Object recognition is temporal cortex. Then our actual question, purposeful scanning. We call this as saccades. Suppose if I am scanning this entire room, what is actually there? The scanning type of eye movements we call saccades, frontal eye field. I am talking to you now. Suddenly moving object, something is flying on this side. I will look here. Suddenly I will look here. This is reflex. Reflex scanning. While talking to you, if something is coming from this side, I will look there because of a reflex. This is reflex scanning, that is superior colliculi. Two important things: regular, routine, purposeful scanning, saccades, frontal eye field. Suddenly something is coming because of a reflex, I am looking there. That reflex scanning, saccades, superior colliculi. Very simple. Purposeful scanning, saccades, frontal eye fields, reflex saccades. This may be one of the future MCQ. Reflex saccades, superior colliculi. While going for walking in the morning, you are scanning the environment. Suddenly you are finding a jet flying in the sky. You will look that. Your eyeball will smoothly track that moving jet. That is smooth movement, smooth pursuit movement. Follow moving object. You are scanning, suddenly you are finding a jet, you are putting your fixation on that jet, your eyeballs will smoothly move tracking that jet movement. That smooth pursuit movement following moving objects, very important area, cerebellum. And next important thing, if my head is moving in this direction, I am still looking at you. If my head is moving in this direction, I am still looking at you. Head is moving in this direction, eyeballs are moving in opposite direction. What is this reflex? Vestibulo-ocular reflex. Important area, vestibulocerebellum. Vestibulocerebellum. Simple. Small revision. Thalamic nucleus, lateral geniculate bodies. Visual cortex, occipital calcarine sulcus. Where pathway, parietal. What pathway, temporal cortex. Purposeful scanning, frontal eye fields. Reflex saccades, superior colliculi. Smooth pursuit movements, that is follow moving objects, cerebellum. Vestibulo-ocular reflex, your head is moving in one side, eyeball is moving in opposite direction. Vestibulo-ocular reflex, vestibulocerebellum. So this question, the answer is frontal eye fields. Next question. Which of the following areas of the brain are correctly matched with the neurotransmitters they release? Substantia nigra, dopamine, locus coeruleus, acetylcholine, raphe nucleus, serotonin. What do you think is the answer? Substantia nigra, particularly pars compacta, it is the dopamine. Locus coeruleus, always remember, it is not acetylcholine, most importantly, it is norepinephrine, locus coeruleus. Raphe nucleus, definitely it is serotonin. So 1 and 3 looks correct, so 1 and 3. Locus coeruleus is for norepinephrine. Next question. Pressure volume loop of the left ventricle is shown below. Which of the following changes shifts the curve from ABCD to ABC dash D dash? What do you think? We know the pressure volume concept, this graph, we know the concepts, but a small twist here, that's all. What you need to understand, the physiological principle behind this, we are definitely seeing, most importantly, left ventricular pressure increases. Why? Because the problem is there in certain things that are coming after the left ventricle. What is coming after the left ventricle? Aorta. That is why we call this as afterload. Afterload. Whenever there is increase in afterload, the ventricle have to work more. The ventricle have to work more. When there is increase in afterload means something concerned with aorta, our total peripheral resistance. So this question is totally about the afterload. They are not directly asking, they are giving indirectly total peripheral resistance. So increased peripheral arterial resistance, this is the answer. So there are 4 options here. We need to correctly identify how the graph is going to look like. So the pressure volume graph and the 4 options. Let's look one by one. First, because of increased contractility, which can be definitely due to sympathetic nervous system, increased contractility. Very simple logic. Look carefully. The graph exactly looks like this. For the given n diastolic volume, ventricle is generating more pressure. Because of that, more volume is ejected out. So that at the end of systole, very less blood is remaining. Because the force of contraction increases, lot is going out, very little is left inside. What I told you so far, pressure generated is definitely greater. Sympathetic increase in force of contraction, pressure generation. Next, end systolic volume decreases. End systolic volume decreases because more force, more pressure, lot is going out, little is left inside. Correct? Next, increase in venous return. Venous return obviously means preload. This is the graph which is going to look like, very simple. Increase in venous return means increase in preload. Preload means always end diastolic volume. So there is increase in end diastolic volume. There is increase in end diastolic volume. So whenever there is increase in end diastolic volume, the force of contraction increases. This is according to what law? Frank-Starling law. Simple, guys. Increase in venous return means increase in preload. Increase in preload means increase in end diastolic volume. When the end diastolic volume increases, force of contraction increases. Force of contraction increases. According to what law? Frank-Starling law. Now coming to the answer for our question, increased peripheral resistance. That means I told you the graph will definitely look like this. This is actually the one expected. But what is the one that is given in the question graph, that also will explain you. First, the normal regular one. Increased peripheral arterial resistance means afterload, I told you. Increase in afterload, what will happen? Left ventricular pressure increases. When there is more pressure work, when there is more pressure, left ventricle will suffer. Left ventricle will invariably suffer. It cannot tolerate the increase in pressure work. Definitely, increase in afterload. When there is more pressure means that ventricle will fail. So, the end systolic volume will definitely increase. Ideally, the graph should have end systolic volume increase because it's a failing ventricle. It is not able to eject out completely. There are a lot of blood still inside at the end of systole. So, end systolic volume have to increase. But in the question which you clearly see, there is no change between end systolic volume and end diastolic volume, only the pressure rises. This is at that particular moment they are recording. See, there is increase in afterload. Immediately if you record, there may not be much changes in end systolic and end diastolic volume. Only the pressure generated by the ventricle increases. Immediately at that moment, in experiments they do this, increase in afterload. Quickly we will measure, only the left ventricular pressure rises. Volume will not change, but if it continues for long term, you see in patients, for example, hypertension. So, anything affecting your aorta, if you see that in patients long term, definitely end systolic volume will increase because it's a failing ventricle. But in research purposes, if you do that immediately after that increase in afterload, you may not see the changes in volume, you will only appreciate the change in pressure. So, we can definitely choose the answer as increased peripheral arterial resistance. And final option, decrease in afterload. This is very easy work. This is definitely very easy work for our left ventricle. Decrease in afterload. Less resistance, left ventricular pressure decreases because easy work. When the afterload decreases, when the resistance decreases, it is very easy work for our left ventricles. So, more will be ejected out. So, end systolic volume decreases. So, decrease in afterload, easy work. Left ventricular pressure generated definitely decreases. It can function very effectively. Lot will be pumped out. So, end systolic volume decreases. End systolic volume decreases. The answer for our question is this, increased peripheral resistance. Alright guys, now let's move into the next question. This is particularly from the GI secretions. Which of the following sites has the least concentration of sodium ions in the fluid? Remember, they are asking about the least concentration of sodium ions in the fluid. It should be definitely salivary gland, salivary secretion. Why, sir? Let's look here. See, this is a repeat topic. There was previously one question asked from the salivary secretion. So, let's have our concepts clear. For salivary secretion, you need two important things. First is the acinar cells. Whatever thing the secretion from this acinar cells is called as primary secretion. This primary secretion is similar to plasma, that is having more sodium and chloride. That means to start with, it is never less sodium. Always remember to start with the primary secretion. It is very similar to plasma, which is having more sodium and chloride. This is the primary secretion from acinar cells. Later, it will be modified by ductal cells. What these ductal cells are doing? They will reabsorb sodium and chloride. They will secrete potassium and bicarbonate. This is extremely important. Acinar cells, primary secretion, similar to plasma, more in sodium chloride. Ductal cells, modification. What is that modification, sir? It is modifying the primary secretion. Sodium and chloride are reabsorbed. Potassium and bicarbonate are secreted. And the most important thing, particularly according to me, this is the extremely important point, why the sodium is low. Not just simply because of reabsorption, the ductal cells are impermeable to water. The ductal cells are impermeable to water. Because of this reason, always remember guys, saliva is considered to be hypotonic. Water stays there. We are taking out only whom? Sodium and chloride. water stays there. The ductal cells are impermeable to water. That is why saliva is hypotonic. Mainly in the ductal cells, sodium chloride reabsorption, potassium and bicarbonate secretion. Particularly this sodium reabsorption is accelerated by aldosterone. That is why primary hyperaldosteronism, there is enhanced sodium reabsorption leading to salivary sodium levels very low. In primary hyperaldosteronism, because of excess levels of aldosterone, more sodium reabsorption, that is why salivary sodium levels are very low in primary hyperaldosteronism. So, aldosterone helps in sodium reabsorption. So, which secretion is having least sodium? Salivary secretion. Now, which of the following hypothalamic nuclei are responsible for leptin resistance? Actually, you can rule out options and get the correct answer. Remember para. Para means I always say parturition. Parturition. Which one? It is our oxytocin. Paraventricular nucleus concerned with parturition oxytocin. Lateral nucleus is our feeding center. Ventromedial is our satiety center. So, obviously, even if you rule out other options, we are left with arcuate nucleus. That is the answer here, arcuate nucleus. You need to be very strong in your concepts also. Look here, arcuate nucleus, it basically has two important group of neurons. The first group, agouti related peptide, neuropeptide Y. Remember, agouti related peptide, neuropeptide Y, they are concerned with the feeding. The second group of neurons, cocaine amphetamine regulated transcript, that is CART, and POMC, pre-opiomelanocortin. See this POMC, it is concerned with satiety. So, which one is for feeding? AGRP, neuropeptide Y. Which one is for satiety? CART, POMC. Now, what leptin is going to do, sir? Always remember, leptin is concerned with satiety. So, it will stimulate this satiety group, it will inhibit this feeding group. We are clearly seeing leptin from the adipocytes is inhibiting the feeding group, stimulating the satiety group. What happens whenever there is leptin resistance? Opposite will happen. The feeding group is not inhibited, excessive food intake, obesity. Leptin resistance, obesity. So, feeding group is not inhibited whenever there is leptin resistance. All this important event happens in arcuate nucleus. That is why leptin resistance affects arcuate nucleus. Next, a very recent question. The Nobel Prize for Physiology and Medicine in 2025 was given for, even I shared this immediately when the news was announced, I put this as a story in my Instagram page. So, this is like a free giveaway question, very easy to answer. The Nobel Prize for Physiology and Medicine in 2025 was given for peripheral immune tolerance. Why? What is the basis behind this? You need to understand, because lot of future questions will come from this Nobel Prize area. What is this peripheral immune tolerance, sir? It all starts with this mouse. What is this mouse called as? Remember, scurfy mouse. What is the meaning of scurfy, sir? Important skin disease, lots of scales, dry scales are there in this animal skin, and also it died due to fatal multi-organ autoimmunity. So, there is development of autoimmunity because of a particular mutation. What is that mutation, sir? It is seen in FOXP3, forehead box P3. Who identified this mutation? Who identified this FOXP3? Two important names, Brunkov and Ramsdell, who actually identified the gene FOXP3 and its mutation, FOXP3. Normal function, what this FOXP3 codes for, sir? Regulation of regulatory T cells. We have Tregs. These Tregs are the ones concerned with peripheral immune tolerance, which means you have to actively suppress our immune system. Then only you can prevent autoimmunity. You have to actively suppress our immune system. Then only you can prevent autoimmunity with the help of this regulatory T cells. Who actually named them? Who actually named these cells as regulatory T cells? Sakaguchi. Sakaguchi identified these regulatory T cells. He actually named them as regulatory T cells. So this FOXP3, Brunkov and Ramstel, regulatory T cells, Sakaguchi. These three got the Nobel Prize. Now, what actually happens whenever there is mutation? Fatal autoimmune disease, because in the periphery, immune cells are not actively suppressed, leading to autoimmunity. Very important, who will be deficient here? Regulatory T cells. And what is the classical syndrome, sir? IPEX syndrome, which stands for immune polyendocrinopathy, enteropathy, X-linked. It is X-linked because FOXP3, X chromosome. It is X-linked. Remember, X-linked. IPEX syndrome. Immune polyendocrinopathy, enteropathy, X-linked syndrome. It's a type of autoimmune disease. It's a fatal autoimmune disorder. That is why it is seen in this mouse. You can definitely ask me why this area got Nobel Prize, sir. First and foremost, remember guys, there is cross-species validation. It is the effects are seen in the animal. You can extrapolate that to humans, IPEX syndrome. Second, there is something called as transformed immunology, which means we had idea about the central tolerance mechanism. We never had any idea about the peripheral immune tolerance. After this discovery, we came to know that there is something called as peripheral immune tolerance. We can devise medicines nowadays targeting these pathways. There is classical textbook rewriting. So previously we don't know something, now we know a lot about that. So information have to be changed in the textbook. There is something called as peripheral immune tolerance. So that is how they award Nobel Prize. Simple. Cross-species validation is there. It's a type of a transformed immunology. That means a transformation in our understanding. Textbook rewriting. It is awarded for Brunkov, Ramstel and Sakaguchi. They got the Nobel Prize. Alright guys, now let's look into the next question. Parathormone is increased in parathormone, another very favorite topic, particularly in INI-CET. Parathormone is increased in, I think actually many students confirmed this, it was asked about the increased. Immobility, familial hypocalciuric hypercalcemia, vitamin D toxicity, thiazide diuretics. With some very basic physiology concepts, we can definitely solve this. The answer is B. Familial hypocalciuric hypercalcemia. Why are we excluding the other options? Let's find out. All the four options are here. Immobility. Immobility. There is no stimulus available for the bone growth now because it is immobile. Immobility leading to increased bone resorption. Whenever there is increased bone resorption, more calcium. High calcium means you don't need parathormone. Parathormone will be low. Simple. Immobility, there is no stimulus for bone growth. There is exaggerated bone resorption. When there is bone resorption, high calcium means low parathormone. Low parathormone. Familial hypocalciuric hypercalcemia. See guys, in parathyroid gland, we have chief cells, correct? These chief cells store and release parathormone. For this release of parathormone, you need something called as a calcium sensing receptor. Whenever there is high calcium, this calcium sensing receptor is inhibited, leading to inhibition of parathormone release. This is normal physiology. When there is low calcium, you need a parathormone. This low calcium stimulate CASR, leading to release of parathormone. We are talking about the normal physiology so far. Chief cells, calcium sensing receptor. Whenever there is high calcium inhibit this calcium sensing receptor, inhibition of PTH release. Low calcium, stimulate this calcium sensing receptor, stimulation means there will be parathormone release. What will happen whenever there is calcium sensing receptor mutation? Now this CASR is having mutation. High calcium cannot suppress PTH. Because of mutation, high calcium cannot suppress PTH. So what will automatically happen? Calcium is conserved. There is high calcium, hypercalcemia. PTH is not suppressed, elevated levels of PTH. PTH is causing calcium conservation, that is why hypocalciuria. So from the urine, there is lot of calcium reabsorption. So less is moving into the urine because of parathormone. So here because of CASR mutation, high calcium is not suppressing PTH. Elevated levels of PTH, obviously option B, familial hypocalciuric hypercalcemia. Vitamin D toxicity, vitamin D increases calcium absorption from the gut. When there is more calcium, low PTH, high calcium, low PTH. Another favorite topic, thiazide diuretics. Thiazide diuretics can cause hypercalcemia. So, high calcium, low PTH. In a previous session, they asked thiazide diuretics. Thiazide diuretics, basically high calcium. Thiazide diuretics, hypercalcemia. High calcium, low PTH. So, in which of the following options PTH is actually increased? Familial hypocalciuric hypercalcemia. Now, next MCQ. Homeostasis is the ability to maintain internal stability. Which of the following best represents stable homeostasis in a critically ill patient? Very beautiful question, thought provoking, but just a simple fact you need to remember here. The answer is obviously urine output concerned with the kidney. The important key word here is stable. What is the meaning of stable? Stability, sir? It is slow changing, that's all. He is a very stable person. Stable always means slow changing. It's a long term. For acid-base balance, for homeostasis, body fluid, volume, everything long term always means role of kidneys. Long term, for blood pressure regulation, for blood volume regulation, for acid-base balance, long term always means role of kidneys, slow and steady. Comes in the end, but main hero is always kidneys. So, long term role of kidney, slow changing, that is why urine output. What about other parameters, sir? Respiratory rate, PO2, heart rate, they are widely fluctuating ones. They are fluctuating variable, but here we are interested in the slow changing one. So, slow changing, stable always point towards role of kidneys, urine output. So, other parameters are widely fluctuating. Right guys, now let's look into this next question. During inspiration, the systolic blood pressure decreases due to. During inspiration, systolic blood pressure decreases due to. Very simple. It is about the increased venous return to the right heart. It transiently reduces left ventricular filling. Simple logic. What happens during inspiration, sir? Remember, the intrathoracic pressure becomes more negative. When the intrathoracic pressure becomes more negative, it is very easy for the venous return now. Increased venous return to right atrium, so there is very good right ventricular filling. When there is increased right ventricular filling, momentarily, transiently, there is reduced left ventricular filling. Reduced left ventricular filling, reduced stroke volume, fall in systolic blood pressure. There is normal inspiratory drop in systolic BP less than or equal to 10 millimeters of mercury. That means the fall can be up to 10 millimeters of mercury for systolic blood pressure during inspiration. Now, look into this beautiful graph. Where is that normal marking, sir? It can be up to 10 millimeters of mercury, the fall. But if it is falling more than 10 millimeters of mercury, what is that called? Are we clearly observing? Inspiration. There is exaggerated fall. There is exaggerated fall, which is called pulsus paradoxus. This is none other but our pulsus paradoxus, which is fall in systolic blood pressure, which is actually more than 10 millimeters of mercury during inspiration. Fall in systolic blood pressure, which is more than 10 millimeters of mercury, which is more than 10 millimeters of mercury during inspiration, that is called pulsus paradoxus, classically seen in cardiac tamponade. Cardiac tamponade. Normally, there is fall in systolic blood pressure during inspiration, which can be up to 10 millimeters of mercury. If the fall is more than 10 millimeters of mercury, systolic BP during inspiration, we call that as pulsus paradoxus. Fall in SBP more than 10 millimeters of mercury, pulsus paradoxus, cardiac tamponade. Simple. Now, which of the following is the most common regulatory mechanism for magnesium? Magnesium balance is always about the kidney. The answer is renal reabsorption. A very beautiful concept. Look here. This is our thick ascending loop of Henle. Thick ascending loop of Henle where we have our sodium potassium 2 chloride cotransporter. So, who will come? Sodium, potassium 2 chloride. Now, this potassium actually will have a recycling, that is through ROMK, renal outer medullary potassium channels, leading to potassium recycling. Potassium is moving into lumen positive. There is lumen positivity. Because of this positivity, positive charges gets repelled. And who are all they? Calcium and magnesium. See, because of this positivity, calcium and magnesium which are positive gets repelled and they actually move into blood for reabsorption through tight junctions. That is why we call this as paracellular. Tight junction means which important protein? Claudin. It is particularly claudin 16. This is how calcium, magnesium, see for magnesium particularly 70% which is very high. Magnesium 70% reabsorption in thick ascending loop of Henle. Majority of the substances reabsorption maximum in proximal convoluted tubule, but for magnesium it is thick ascending loop of Henle 70%. So, this is tight junctions paracellular claudin 16. This normal process is actually accelerated by parathormone. Parathormone helps in increase in magnesium reabsorption, and if you block this channel protein, no magnesium reabsorption. That is why magnesium reabsorption is decreased by loop diuretics, furosemide. Magnesium reabsorption is increased by parathormone. Magnesium reabsorption is decreased by loop diuretics like furosemide. Loop diuretics decreases magnesium reabsorption. What happens whenever there is mutation in this claudin 16? Then also magnesium reabsorption will not happen. We call this as familial hypomagnesemia because all the magnesium is excreted in urine. Familial hypomagnesemia with hypercalciuria. Calcium also excreted in urine leading to renal stones. Nephrocalcinosis. We call this as FHHNC. Familial hypomagnesemia with hypercalciuria and renal stones, nephrocalcinosis because of claudin 16 mutation. Remember, magnesium reabsorption regulated at the level of kidney, thick ascending loop of Henle, 70% magnesium reabsorption. Next, identify the type of receptor given below. Any idea? It is about the ATP hydrolysis, and this important channel protein is moving a substance from inside to outside. For that it needs energy, ATP hydrolysis. It is none other but our P-glycoprotein. What is the importance of this P-glycoprotein, sir? Remember guys, there is ATP hydrolysis to move substance from inside to outside. Most importantly, this substance is going to be a drug, throwing from inside to outside. It needs ATP. What is this called as, sir? ATP binding cassette transporter, ABC, ATP binding cassette transporter. When there is ATP hydrolysis, we obviously call this as primary active transport. Primary active transport. I already told you it is about the drug efflux, like bouncers standing in the club. This P-glycoprotein is like a bouncer. So, any drug or anything that is coming inside, it is quickly thrown out. So, drug efflux. That is why a very important other name, multi-drug resistance protein, because cancer cells, tumor cells upregulate this P-glycoprotein. So, if you give any drug to treat that cancer cell will quickly throw it away, thereby leading to drug resistance, multi-drug resistance protein 1. Even more important thing, it is highly expressed in blood-brain barrier, leading to tumor chemoresistance. Very, very thought-provoking question. P-glycoprotein belongs to ATP binding cassette transporter. Very simple. For its functions, it needs ATP hydrolysis, primary active transport. What is the function of P-glycoprotein? Throwing a drug from inside to outside. That is why it is called as multi-drug resistance protein 1, because tumor cells upregulate this P glycoprotein. You give a drug to treat the tumor, the drug will be thrown out. Drug resistance. P glycoprotein is in blood-brain barrier, very important location, leading to tumor chemoresistance. So nowadays we are developing the blockers for this P glycoprotein for cancer chemotherapy. So we are developing the blockers for this P glycoprotein. Simply remember P glycoprotein as bouncers. It needs energy in the form of ATP, primary active transport, P glycoprotein. These are all the important 11 questions we got from physiology. As I told you, there are many more. If you look into other subjects also, physiology interrelationship is there. We know the pattern recognition already. It is largely clinical integrated questions with a very slight twist in the basic facts. So this you use as a learning tool, this recall recordings. Many questions will come from the related topic, not the question as such, from the topic. For example, parathormone, thiazide diuretics, questions are bound to come. So please to watch this revision videos carefully and use it for your preparation. Good luck and best wishes guys as always. Thank you so much.